our Caribbean African targeted health program, along with its national partners, I'm incredibly pleased to continue to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, Black GPs or consultants present on health and well-being topics that you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we continue to respond to the needs of our Black community. To request any particular topic, please email help@can.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.
Good morning, everybody. Good morning and welcome to the Catholic Health Hour on this, the 21st of October. October already, doesn't it feel like it was only just February last week? My name is Dr. Ayo Latoe. I'm an acute medicine consultant and I'm going to be your host for today. We've got a jam-packed session for you. It's going to be really good, as these sessions are. And we want to take the time to acknowledge our collaboration with other organizations that make the CATHIP possible. So we want to acknowledge RAFA, International Agency. We want to acknowledge Croydon BME. We want to acknowledge Enfield Caribbean Association, the Royal Assembly Sheffield RCCG, that's a church. We want to acknowledge the Black Health Initiative. And obviously, you know, here us at CAN, we're working together for the purposes of making sure that the conversation about health in the Black community is furthered and dealing with inequalities in healthcare. So like I said, thank you to all our partners and thank you for attending, because these sessions wouldn't be the same without you. Like I said, we have a jam-packed session for today, and actually it's going to be in two parts. Usually there's one conversation, but we're going to have two conversations today, so you can get your money's worth. And I want to, without further ado, Dr. Kamara is here. Okay, so we were having some technical difficulties, but I just want to make sure that Dr. Kamara is on the stream. He's no stranger to Khan. Are you there, Dr. Kamara? Natasha, I think for time's sake, maybe we can just do the other presentation first. Fine. What I'm going to do is I'm going to take the opportunity to introduce Dr.
Harry, just 1 second, just a bit of a technical issue, but we're joining.
Oh, okay.
Won't be long.
No problem. Okay, in that case, and what we'll do is we will we're going to wait for Dr. Kamara, but let me just ask everybody, how is everybody doing this today? How has your week been? Tell me on a scale of 1 to 10, so 10 being the best ever, you won the lottery, you got married, you had a baby, and 1 being, you know, you got fired. How has your day been? I'm going to put mine in the chat. On a scale of 1 to 10, how has your day been? Mine has been an 8. Your week, rather. Natasha's been a 7. So how has your day been? 10 is the best thing ever, and 1 is the worst thing ever. How has your day been? Your week, sorry. 7 to 8. 7 to 8. Okay, that's good. So far, everybody's above 5. Okay, thank you, Ernest. And 8. 7. There we go. The answers are coming in. Good, good, good. I think it's really important sometimes to take stock and you say, okay, looking back at the day. So we've got lots of 7s, we've got lots of 8s. If we do have any 1s and 2s, especially if you don't want to acknowledge it, I'd like to remind you that your current track record for surviving difficult days is 100%. So it has been a difficult day, it's been a difficult week, but your current track record is 100%. You can do it, you can move forward. So yeah, we've got they're still coming in. We've got 7s, we've got 8s. Fantastic. And while we're on the topic of it, because oh, there's Dr. Kamara. I recognize his handsome face. Fine. So I think we're about ready to get started. And somebody's raised their hand, but I think we're probably going to do questions and things later. But yes, I want to take the time to thank Dr. Kamara, who is a specialist in emergency care and no stranger to Khan. He's like the furniture around here. You recognize his face. He's going to talk to us today about chronic back pain. So he's going to talk to us about chronic back pain. Dr. Kamara, thank you so much for your time. Thank you for persevering through your technical difficulties. We're looking forward to what you have for us today. And whenever you're ready, Dr. Kamara, you can unmute. Take it away.
Yes, thank you so much for that intro. Can you surpass that? Right. So I think not so long ago we did acute pain, focused mainly on back pain, but and I think the suggestion was I needed to do an on-call, if you like, or follow through, and so this came to pass, as it were. So you might notice the date is tomorrow's date, which is what I was supposed to be doing. So it's not an error. It's just that I had to come here at short notice, and hence the reason why it's dated tomorrow's date. But I was supposed to be presenting tomorrow at another forum. Yeah, as you can see, all hands on deck. So I don't know whether we've got time, but I wanted to try and see whether anybody can see any word here. And then maybe I can say a couple of words, but maybe we've run out of time for that because I presume we have a very tight schedule. Now, obviously you can see chronic pain is the title, and it's a very complex topic, as it were. There's no way you can finish that in about 30 minutes or 45 minutes. But suffice to say that this is such an important topic that the World Health Organization, under the aegis of World Health Assembly, declared September, which is just gone, Pain Awareness Month. This is just to raise public awareness and an understanding of the pain that is afflicting the population of the world. So, without any further ado, what do we mean by chronic pain? Now, pain is acute until it's up to 12 weeks, 3 months. Thereafter, it becomes chronic. One thing we must know is that there's no specific area. Of course, there are areas where it's more prevalent than others, but it can happen anywhere in the body. It can be intermittent and it can be constant, which is different from the acute pain. I hope people remember what the acute pain was like when we discussed it. And in the context of chronic pain, there is a sub-context of high impact chronic pain, which is severe in comparison to chronic pain, and it's associated with inability to carry out our daily activities, daily chores, cooking, cleaning, school runs, working and all that. It interferes with the social life and even the personal hygiene, and it can lead to a lot of issues, including mental health issues, depression, anxiety, insomnia, problems or difficulties sleeping, and it creates this cycle, which then becomes very, very difficult to break if you're not careful, and therefore the reason for raising the awareness. So as we can see, chronic pain can be because of a nerve problem, which we term neuropathic. So it could be because of this pain in the lower back, which we term or we call sciatica, where you got pain in the lower back and it goes down the back of the leg, down to the foot, or down to the, down to the top of the big toe and things like that. It could be because of diabetes, could be because of smoking, where you have the nerves of the lower limbs being impacted as a result. You've got this sensitivity deficit, It could be because of muscles, which can be in the legs, in the neck, in the shoulders, in the back, anywhere. And it could be because of wear and tear, So we call that compressive or mechanical pain, which can involve the spine, and in so doing, the spinal cord. The discs, which are the cushions between the bones, as we spoke about the last time we did it, which was in the acute pain, do wear, they get dried up. And so therefore, bone on bone will cause you a lot of pain. So that could be that kind of pain. And it could be because of inflammation, because of arthritis and other things, So this gives us a bit of an insight as to how prevalent this problem is. Now, if you look on the right, you'd see that in our parts of the world, developing countries, this is up to 25% of the population suffering from chronic pain. In the US, and later on you'll see what happens with the UK, there's about 1 in 5. Imagine that, 1 in 5, 1 person in 5 suffering from chronic pain. And you have 8 out of 10 of those people, of those patients, suffering with depression because of the pain, mainly. And then you have 1 in 4. So 25% have problems sleeping. And of course, as you know, the world's population, maybe 8 billion and counting. And I think it's maybe a bit more than that, because since the pandemic, people were just having babies and things like that. And so obviously it'll be a bit higher now. I don't know if there's any consensus. But anyway, we know 8 million because that's what we were aiming for during the pandemic in terms of the vaccines. So we envisaged we needed 16 billion, for every 2 that we were looking into. So 10%, imagine. So 8 billion and 10% of that, I think if my maths is correct, is 800 million. That's not a small number, really massive that. So it's a big, big problem, and it's a real problem. This is a beautiful slide that I thought you'd enjoy. If you look at the left, you'd see that, well, unfortunately, women, because of the way they've been designed by nature, they suffer a bit more. But that is not to say that's like that all the time. As long as they have periods, that monthly period, theirs is less in comparison to us, the men. But as they grow, dare to say older, they get past the menopause, it increases. And as it were, you would see that 38% versus 30% for men. As the age increases, as you can see, from 16, you could see that by the time you get to 65 or thereabout 70, you'd see that increases from 18% to 49, 53%. So half, of the elderly population would have some amount of, pain, and it may well be chronic. Now, we mentioned where it's prevalent in the body. As you can see, the hands, arms, and legs and feet, obviously they're more prevalent because these are the ones that we use all the time. They're the ones that keep us on the go, keep us moving. The back, obviously is what keeps us upright and keeps going, and that's what we abuse mostly. So it comes not far off really, and then of course the neck, well, the stomach, as you can see, and then of course the chest. Now chest people take a lot more seriously because of the issues with the possibilities of a heart attack and obviously death. Again, you can see on the bottom right that you have the weight, the habitus, is one thing that impacts the prevalence of the back pain. You can see the heavier you are, the more likely that you are to have this chronic back pain. As you can see, 29% for the ones who are underweight. So people think that because you're underweight, you can't have chronic pain. Well, that's not true. As you can see, it is there. But obviously, the one who is very, very overweight would have up to 54% chance of having that. So again, this one just illustrates the prevalence of it. What's the commonest condition associated with chronic pain? As you can see, arthritis, which we're all hearing about and know about, seconded by back and neck pain. And of course, when it becomes an issue with the joints, then it causes chronic pain as well. And then of course, last but by no means least, you have nerve pain, which is about 10%. So how does it come about? How do people describe or where is it and the rest of it? And you can see that in different aspects, if it's a nerve effect, you can see it's neurogenic pain, which is near where the nerves are in the body. And then of course muscles, sometimes even the scars, you had a cut, maybe you fell and sustained a wound or a cut and it heals, and sometimes surgery, that can cause pain. And of course headaches, including migraines, we get. Cancer, we know, causes pain, especially the ones of the bones, they really cause a lot of pain. Arthritis, we've seen, and of course there you see back pain and neck pain. So this, I thought, would probably highlight what I'm talking about. So as you grow older, you would see that you're more likely to develop chronic pain, especially so when you are disabled, as it were, because obviously you demand a lot more use of the back and the other parts of the body when you're disabled. But it's more likely to be happening in the latter aspect of life, so in the 60s. When you're young, probably you compensate, you mask that, you cope well, you adjust well. But as you grow older, the sensitivity becomes less. And I think you'll get to find out as we go into this talk. So suffice to say that we are more prone to having chronic pain as Black people, 44% likely in comparison to our Caucasian counterparts, who are 34%. And just above them, you have the Asians. And if you look at the figure below, you'd see that mixed, multiple ethnicities and people with different ethnic backgrounds are less so. As we see, chronic pain affects, women at 14%, and about 9% of the men who suffer with that have less in comparison to the women. They have more chronic pain, which is of high impact. If you remember, I mentioned that earlier on. And of course, people who lived in deprived areas do have a 30% possibility in comparison to the ones who are in affluent areas. That is not to say the ones who live in affluent areas do not have that. They do have that, but obviously in less, if you like, a percentage, as it were. And of course, one thing we've noticed is that since 2017, and maybe during the pandemic, because of the sedentary lifestyle, the lockdowns and all that, there's a rise of chronic pain in the young adults, from 21 to 32%. You'll get to find out what happens with children as we go into the talk. So there we go. 50% of those afflicted with chronic pain or by chronic pain do have a problem with performing their daily chores, as you can see, as illustrated on the top left. And of course, on the right, top right, you would see that the sickness certificates, the sick notes that we issue almost on a daily basis are mainly because of chronic pain and mental health problems. And on the bottom left, you can see that people who have chronic pain, 50% of them do believe that they have little or no control over their pain. And so it just tells you how important this subject is, or this topic is, for us to know about it. 14% of them obviously report that it's severely disabling. And of course, a large proportion of them do have a problem sleeping at night or during the day, depending on what you do. But I like this slide, and I thought I'll tell you what the risk factors are. Now, one thing that springs to mind is this first top left, poor posture. Since the mobile phone and the tablets and the electronic age came into being, this is what we've been doing to ourselves. Poor posture. It's one main reason why we do have pain in the back, in the neck. Look at the other one in the middle there, poor ergonomics. That's why most of the secretaries who are doing this work on a daily basis do have specially designed chairs and tables just to help them, in the long term. And of course, look at that. Our ladies, they like wearing these high heels, but if you are wearing the wrong footwear, you're more likely to develop that, And as you age, of course, you're more likely to develop chronic pain. Being overweight, we said that already. Injuries, trauma, athletes, and the others who do that for a living are more likely to develop that. Being a female, as we said already, and of course, one main factor is the genetic side of things, So if it's in the family, it runs in families, there is a higher risk or a higher percentage or a higher chance of you actually developing that. This is just, again, emphasizing the point that obviously, the chronic pain is a real thing, because you have causes there, which are like back pain, headaches, muscle sprains, cancer, broken bones, surgery, and of course, injuries with the nerve, And then, of course, you have treatment, which is a variety, a combination. It could be one, it could be an overlap of the others. But we'll get to find out that as we go on. So I thought I'd compare, because it's just reminding you what acute pain is, comparing it to chronic pain. Now, acute pain, begins all of a sudden. It's like it happened suddenly. So, oops, you stood up, or maybe you were going into the car, and then, oops, you felt the pain, and that stopped you, and you just froze. It's sharp, it's intense. In comparison to the chronic one, it varies in intensity, as you would find out, and the pain is constant and intermittent when it's chronic. With acute pain, it's actually caused by something specific, like illness, injury, and it warns you, because you feel the pain, you would want to actually find something like a cure or like a treatment for it. It warns you that something is wrong, and definitely lasts less than 3 months. It can rectify itself, or maybe with help with medication or treatment or exercises and things like that. And the issue with the chronic pain is that it lasts more than 3 months. So if the brain has actually coped with it for 3 months, thereafter, the brain actually accepts it as normal. And then the body says, hang on, this is not normal. So there is that constant battle. And that's where that cycle comes in, that cycle of pain, which is really, really important to understand. So this is the one I'm talking about, the persistent pain cycle. And the pain comes in and it's more than 12 weeks, it's persistent. And then you then begin to become, what's the word for it? Deconditioned, the muscles, because you're not walking as you should, and you're in bed for fear of the fact that if you get up, the pain will get worse and all that. You begin to decondition. And so the muscles begin to wear off, i.e. they become a bit atrophied, less powerful, less bulky, and of course, that then causes problems for fitness, for work. The joints get stiff, the muscles get weaker and atrophied. And then there are things you worry about in terms of what can I do, what can I not do? For fear of what's going to happen, for fear of the pain, you then create a list. And then that leads to worry, and the worry leads to problems with sleeping, and the sleep and lack of sleep leads to stress, as it were. And then one thing it does is it causes depression, it causes fatigue, it causes negative thinking. And in so doing, because you are now inactive, you could put on weight. And that, of course, we know is a risk factor. So it's like a vicious circle, as you see. And then the other thing you have is you then have the medication that you have to take to alleviate the pain, to help you with the pain. And that in itself has got side effects. So you've got to deal with not only the effects of the pain, but you also have to deal with the side effects of the pain. So it's a very, very vicious circle, as it were. And I hope people are paying attention and how we can get to break that cycle, okay, break that chain is very important. So there you go. Again, this illustrates it, the chronic pain cycle. The brain becomes more confused on the problem. And then, of course, the changes take place in the system, in the nervous system. And that causes more pain. And that in turn causes more anxiety and less movement, and so on and so forth. So it's a very, as I say, vicious circle. But what does the pain feel like? Now, some people have described it as aching. Some say throbbing. Some say shooting, like electricity. Some say squeezing. Some say sometimes stiffness and stinging, and of course, burning when sometimes the nerves are involved. So this is, I like this slide, and so I thought I'd share this with you. What people see is like the iceberg. We always talk about the tip of the iceberg, and this literally is what it looks like in someone who's got chronic pain. What people see in you is how he's always in pain and things like that, and therefore he's feigning, he's lazy, he's not doing this and that. What they don't see is what you are going through, and you can see that fatigue because you don't sleep, irritability because you don't sleep. Of course, you've got this pain that is there, endless, shooting, disturbing you, irritating you, and causing you all sorts of problems. And that leads to your depression, your discomfort, and all of that, anxiety. But they don't see that. What they see is just the fact that you're just being who you are, and that's it, miserable, so and so. But in actual fact, what you do have is that. So it's important to remember that we need to be empathetic, we need to be sensitive, we need to be supportive in order to break this cycle, this chain. Now, we think, well, children are maybe exempt from this. Well, that's not true. Children do suffer with this. Now, me as an A&E physician or clinician, I worry when a child is brought to me by her parents or his parents saying they've got back pain. I worry because back pain and childhood do not mix. There's really, really a dangerous mix there, and therefore it needs to be taken seriously and investigated. But of course, we know they suffer. So 20 to 35% of children do suffer. And when they do suffer with chronic pain, this is what they get. Yeah, they get irritable, angry. And because they get angry, that affects their relationship. And besides that, the pain causes them lack of sleep. And because they don't sleep, just like the adults, they get tired all the time. And in so doing, they fall behind with their schoolwork, and that causes further stress. And then, of course, when they can't take part in the sports and playing out, which is what children enjoy, full of bins, charging all over the place, up and down, and they can't do that, they're sad, and they find themselves lonely because it affects the relationship. So it tells you what children suffer when they have chronic pain. And this is something we have to try and alleviate and get better. In the elderly, which is the other side of the spectrum, or the pendulum, if you like, you can see now, most of the time, the elderly people, when they come to us, like, for example, they've got problems with the belly. It's just an example. They have, like, some problem in the belly where they have pain. Because of the fact that in their time when they were growing up, they're not allowed to express emotions, for example. They mask it. They underplay it, they trivialize it because they don't want to be a burden. They see themselves as a burden to people. So therefore, this thing could be creeping up. If, for example, there's an ulcer, or maybe there's a bowel that isn't working, it's tangled, or and that, of course, is something that needs to be remedied straight away, or maybe as soon as possible. When that doesn't work, or that doesn't happen because they're masking it, they're not bringing it up or sharing it with people around them, family members, or maybe dementia, or maybe the kind of medication they take, it sort of numbs the pain, makes it less so sensitive, it becomes a problem. So that's something that we need to really understand, that in the elderly, the pain perception is less, the pain threshold is higher, and the sensitivity to mild pain is definitely lower. as I said, the example I give is just the peritonitis, which is the inflammation of the lining of the bowel of the belly, and that would really cause problems, because if you have to operate at a particular time because of peritonitis, the lining of the bowel is called peritoneum, and inflammation of that is called peritonitis. And if you don't operate in time, then that person goes into sepsis, and sepsis leads to shock, and shock leads to multi-organ failure, and then sadly they die. So it gives you an impression and an understanding as to what needs to be. So we need to be very focused, needs to be astute. If we sense any change, in persona, in expression, in the way they are, and it's abnormal or maybe unusual, then we need to be acting and maybe try to eke out what it is that is the problem and try and sort it out in time, rather than wait until they get enveloped by this problem. One thing you must understand is they don't catastrophize the levels of pain, whereas the younger ones do that. The superior pain acceptance and self-efficacy is definitely one thing that actually impacts the way they express themselves with the pain. But as I say, issues with dementia and and mobility and all that, and comorbidities, i.e. the other illnesses, can sometimes be a problem for them. So we need to be very alert to that. So that brings us nicely to the symptoms and the causes. Well, we talked about this already. With chronic pain, you may not necessarily know what the cause is. One can overlap into the other, and of course, things like arthritis, cancer can cause ongoing pain and would not necessarily be the issue, as it were. So if you've got a sprain or a broken bone or a brief infection, changes can happen to your body, which can then remain even though the cause of the pain initially has now completely been remedied. That is important to remember. And of course, you have things like chronic pain being caused not necessarily due to injury or physical illness, but then you have psychogenic pain and psychosomatic pain, which is caused by factors related to stress, anxiety, and depression. As I said already, several causes of pain can overlap, and two different illnesses can coexist. Like, for example, migraine and psychogenic pain. It's very difficult to distinguish one from the other, but they can coexist and they can overlap. This is more for the medics, if there are any medics on board. It just shows you the brain and how it processes pain. And I wouldn't go too deep into that, but as it were, figure 1 is amygdala, which sends the signals to activate the fighting signal. So there's a hormone called fight or flight hormone. This amygdala, number 1 there, as you can see, is the one that actually triggers that into action. And the fourth one, number 4, which you can see, is an area of the brain that helps to decrease the pain. So this is something we need to be working on. Number 4 needs to be helping with that. But it just shows you how it affects the body itself. So how do you diagnose and test for chronic pain? Well, if you go to your health provider, your doctor, your GP, your nurse, consultant, or whoever, they will probably take a good history from you, finding out when this pain started, where it is, how is it, you're describing it to them, and what makes it better, what makes it worse, whether it's associated with anything like numbness, and of course how often you get it, whether it's constant, whether it's numb, whether it's dull, whether it's sharp, whether it goes up to the neck or down to the back, and how is it impacting your life. Now that's very important. If you are suffering to the point where you can't conduct yourself as you would normally, then there is an issue and it has to be taken properly, investigated properly. So in so doing, investigation involves examining you, finding out exactly where the pain is and what it is related to it. There might be swelling, there might be bruising, there might be a deformity, in the area, or there might be a referred pain coming from somewhere else. For example, headache could be because of the neck. It could be because of the medication you're taking. There's something called codeine-induced headaches. There's so many things involved in this. So they will examine you thoroughly, look at your past medical history, look at what had happened to you in the past, what surgery you had, and the rest of it. And then, of course, they'll then go into maybe doing a urine sample, dipping it to make sure it's not, for example, a kidney infection or kidney stone that it may be causing it. And of course, in some cases, it might give you an idea as to a particular type of cancer, which is called myeloma. You've got what we call Benz-Jones protein. That protein can be seen, and a lot of things can be found from the urine. Again, the blood test, different blood tests they can do. And of course, they have the imaging, which will support or help towards getting a diagnosis. You have the x-rays, and if that doesn't reveal anything, then you have CT scans and MRI scans, which would help. They have something like nerve conduction study, which will tell you where the blockage is of the nerve, because the nerve might come from the brain and right down to the finger. So there's areas there where it can block, for example. And so when you do the nerve conduction studies, you would actually find out where the blockage is. They can do reflex and balance tests. And in someone who, for example, has got headache, and you've done some blood tests and they couldn't find anything, but they want to make sure that this person hasn't got what we call subarachnoid hemorrhage, that there's a bleeding there in the brain, but it's not visible on the CT scan because it may be too early, or the MRI scan. Then they will do, as long as they know that there is no increased pressure in the brain, they will then do what they call spinal lumbar puncture. Like people who've had children, they know it looks like the epidural, where they put it there and then they'll see what the pressure is of that liquid that comes out. And of course, whether there's blood in it, and they can take that to test, and that can give them an idea as to what's going on. So there are things that could be done. And then of course, managing it is probably important, because you need to first try and identify. And once you've done that, you've identified, you can then format a plan of treatment or management. And sometimes you can't find the source. And if so, then treating and managing the pain conservatively or symptomatically might be a way forward until you can actually get to the bottom of what you're looking for. So the type of pain, the cause of the pain, if known, your age and overall health, including all of the illnesses that you have ongoing or maybe you've had in the past, and that would format or maybe sort of impact or maybe decide or influence the best treatment plans, which would sometimes include a variety of strategies, and that includes medication, lifestyle changes, and of course some therapies, as we find out now. So this is a slide which is very impressive in my view. As you can see, the kind of medications that people are subjected to when they have chronic pain. Take note of the anticonvulsants on the left bottom there. These are really, really heavy duty medications, and they have a lot of side effects. So before you go into them, you probably well advised to think about, what the side effects are, and what you stand to gain and what you stand to lose. The health providers are definitely duty bound to explain that to you, But most importantly is to remember that some of the medications lead to addiction and sometimes lead to overdose, because there is depression and because anxiety and negative thoughts and all that. And then of course you have at the right there on the bottom, topical, which is something a lot of people, dabble in. They use the ones like the heat pads and the pain pads and things. They do that effectively, and sometimes it helps. Antidepressants, as we can see, they have their role as well, but that is when they would have actually investigated and found out that there are things there that could be dealt with in order to alleviate the mood. So here you go. This is again another illustration of what they use or what we use. But take note of the bottom one there. A lot of controversy. Some people actually say, well, look at, marijuana, weed has been used. That is a topic for another day, but it's for you to know that they've used that. I think in the best hands of the people who actually deal with that, it sometimes can be effective. However, there are side effects as well, but it's called medical because it's probably controlled and managed properly. Look at, we talk about pain treatment, we talk about chronic pain, and of course, we talk about the right side of things there, as you can see. AI springs to mind, as you can see, artificial intelligence, people talk about that, but that's one thing, You've got immersive technology nowadays coming into the fore. You have hydrotherapy, water, swimming, you have physiotherapy, you have occupational therapy, you have hypnotherapy. All of that is just to try and get things going. Tele-rehabilitation, remote patient monitoring. These are all, helpful nowadays, especially since the pandemic broke out. So these are other remedies that have been used successfully to some extent. They have this. I have one myself because I've got this back pain, and I use it. This transcutaneous. It goes through the skin. Electrical nerve stimulation. It's called a TENS machine, which you put around your lower back, and then it actually takes some small shocks through your skin into the area where the pain is. It does work, but I don't think it works for everybody. Some benefit from that and some don't. But whatever works for you is most important to remember is what you need to actually continue with. The nerve blocks in the pain management team, they do that. The anesthetists, the ones that look after the airway, they do these nerve blocks. And of course, they do the injections, which is like an epidural, where they go into the space and they inject this medication to that area, which would help with the pain. As I said, doesn't always work. It works for some, doesn't work for some, and there are complications or side effects which you will see. So if you're taking painkillers, for example, you're taking paracetamol, sometimes people can overdose accidentally or intentionally, because, as I say, the chronic pain might lead them to a point where they just know they've lost it. They have no hope. They become depressed. They become fatigued and all, and that leads to, attempt on their lives. Opioids, the likes of cocodamol, tramadol, morphine, and all that, they are addictive, as are the others, and they're likely to be either overdosed at some point, or maybe addiction can lead to something else. The other medication can lead to mood changes, confusion, and of course we know opioids or opiates can lead to problems with breathing, and sometimes that can obviously be fraught with some danger. The spinal cord can be affected, and sometimes you get infection from the injection. So what do? How can lifestyle, changes be helpful? Remember, stress is a major role player in chronic pain. So it's important to reduce the amount of stress. Now, I say that, but obviously stressors, don't get me wrong, are good in life, but not overly so. Too much of the stress obviously has got, a negative impact, as you were. So you need to probably have these different techniques that will help to manage your stress. And these probably would include meditation, deep breathing, and of course, whatever works best for you, like I said already, is what you need to be continuing with. Exercise as best you can. Walking, brisk walking is absolutely brilliant. If you have problems with your heart, remember, going up the slope might just put it under too much strain. But nonetheless, you can do that on the flat. But it keeps you going, and that in itself can release the stress in some people. So it's important to try and break that cycle, that chain. The diet, remember, if we have a diet that is consistent or consistently being full or, inundated or saturated with red meat and refined carbohydrates, as has been found, it does. In fact, there's an article that I read yesterday where they said eating red meat twice a week probably influences diabetes, or maybe increases the possibility of having diabetes. I don't know how true that is, but some people might disagree with that, but there it is, food for thought. Sleeping. Quality of sleep is very important. Lack of that would cause weight gain, and of course would worsen the chronic pain. So it's important to manage the stress related to lack of sleep. CBT. It's not the cognitive behavioral therapy. This is the mental health side of things. That is not as straightforward because it's something that is a long-term thing, sometimes 18 months, 24 months. Counseling is absolutely vital. The family can be counseled. The patient himself or herself can be. Occupational therapy does help. Physical therapy, the exercises, the movements, the stretching to strengthen the body, the tendons, the muscles, the ligaments can help to reduce the pain. So yeah, these are all alternative treatments which I hear people talk about, which have got a place in the management. Some people talk about Reiki or the healing of touch, aromatherapy, acupuncture. I know definitely works because I've tried it. It worked for me. Cupping worked definitely. Biofeedback, hypnotherapy, I said already, that does help. Music does help. If you go to any of these places, there's definitely bound to be some amount of music, some form of music which is relaxing, and that in itself helps. So one thing that people always ask is there a cure? Well, I can tell you for certain that there's nothing like cure. Curing chronic pain is definitely not something I would say is available. You can treat the cause when you've identified it, or maybe you still treat it as you are trying to identify it. That might help, but that does not mean you're cured. Something else might just trigger it, and then of course it comes again. If you can't find the cure, that does not mean you should be despondent and just let go or not do anything. Definitely, it's important to remember that a combination of medication, therapies, and lifestyle changes, for example, smoking, trying to lose the weight, controlling the blood pressure, looking after the sugar control and all that, will probably help a lot. So how do you prevent it? Well, unfortunately, nothing has been found to actually prove or proven that the chronic pain can be prevented in general. But other conditions that may well influence chronic pain can be tackled, can be dealt with, can be managed properly, and that could probably lead to a better outcome. For example, just a simple thing, I wouldn't say simple, it's a difficult thing for someone who's definitely smoking. But yeah, if you quit smoking or maybe lessen the quantity of the cigarettes that you take in, it lowers your risk of lung cancer and of course back pain due to poor circulation of the blood in the lower limbs, and that can sometimes lead to trophic ulcers, which can be difficult to heal or to manage. So it's important to remember that one thing like that can actually have a ripple effect. It can have a domino effect on the rest of the body. So as it were, research is carrying on in terms of how to manage, chronic pain and how that could be done, and hoping that in future would have more advances, more answers to give, and more successful ways forward of managing chronic pain. If you do have chronic pain, and on top of that, you have problems with mental health, anxiety, depression, then it's important to probably seek help in the appropriate avenues, if you like. It doesn't usually go away entirely, but you can manage with a combination of the strategies that work for you. I repeat, I can't emphasize it enough. If it works for you, then stay with that. If it doesn't, then it doesn't mean you need to give up, but you need to carry on doing what you need to do and take it from there. So how do they say, it impacts their lives? As I say, obviously it decreases the quality of life, as we know already. It causes anxiety, it causes depression, and sometimes can lead to substance abuse disorders. And of course, it can worsen existing chronic disease. And as I said, more unfortunately, this can increase the risk of suicidal ideation and sometimes lead to fatalities. So this is just an illustration, about the deconditioning and the other associated issues, the depression, the cognitive impairment, this learned helplessness, and of course this is then related to with anxiety and poor concentration and social withdrawal. These are all factors that are stemming from the fact that you lose control of this, and all of that is because of 12 weeks of this physical pain that had not been sorted out. So 23% of those that suffer with chronic pain, I thought I'd share this with you, have obtained a disability pension or have been recognized, for incapacity to work. And you can see that half of the people with chronic pain have changed their profession, something you loved, something you trained for, something you really wanted to carry on to completion. Because of the chronic pain, you've had to swap. You can see that this chap who was working physically has now gone on to something that has to do with less of that demand. Sadly, the right top there, as you can see, 1 in 5 lose their jobs. This is absolutely shocking, and it's a reality. 1 in 5, so it's like 20% of the population lose their jobs because of chronic pain. And as it says, depressingly, as it says, 77% do feel depressed due to the pain. So besides taking medications, what else can you do? You can obviously, lifestyle changes that we talked about already, take good care of yourself and avoid smoking, as we talked about already. Try to calibrate the amount of exercise or the amount of activities you get involved in. Don't do too much, because if you do that, you put yourself off and then you set yourself back. It's like one step forward and 10 backwards. Have a healthy diet, remember that, and get enough sleep. Manage your stress to a level that you think might be okay. And above all, remember, don't suffer in silence. There are groups there that you can join. There's family members, there's therapy that you could actually get involved in. And you can share your own experience with other people, how you coped, how you got better, how you improved. That is a good thing. So these are just myths I thought I would share with you. I think I'm conscious of the time, and I wanted to leave some time for the questions and answers, and of course the vaccinations issue. People sometimes feel that my pain and limited function means there's nothing I can do. That's not true. There's something you can always do, and you might just stumble upon it when you try. And if you tried and that is something that worked for you, then go for it. A scan will give me a diagnosis. That is not true. Many a time that becomes a problem because the scan might not be positive, and if it's not, then you back to square one in pursuit or in search of what actually is causing that, the pain, as it were. I'm causing myself damage if it hurts. Well, that's not necessarily true. I should stay in bed and rest. Well, that's not what you need. You need to be active. You need to be moving about, trying to get the muscles, the tendons, the ligaments, the bones turning over. And in so doing, you'd obviously improve. Bending and lifting will make my lower back pain worse. Well, there is some truth in that. And obviously, I wouldn't say all of that is false. Obviously, it helps because when you're doing the exercises, in some ways, you're twisting and stretching and bending and things. But remember, when you're bending to pick things up or get something that is heavy off the floor, you're using the thigh muscles, the abdominal muscles, and not the back muscles, like we talked about in the first dose of this presentation. These are all myths. Now, I don't know whether I should go through them, but I'm conscious of the time, and I think we can sort of just skip through them. But you can see that these are all questions and myths that people have in their heads, which are not necessarily true. And so when you go to see your health provider, your doctor, your physician, your physiotherapist or occupational therapist and all that, these are probably some tips, questions that you might want to ask them. What's causing my pain? Will it go away? And if not, why not? What kinds of medications can I take? And of course, like we said already, remember, the side effects are very, very important. Not many people are forthcoming with the side effects, and therein lies the danger. Some of our colleagues have been successfully sued because of that. And it's important to remember that the patient needs to go into this fully informed, make an informed choice, open-eyed, thinking, well, yes, this is what I have. My suffering is at this level, but what they're offering is at this level. And what I can get is this, but the price I pay is that. So therefore, what do I need now at this particular time? Is it important for me to consider long-term or short-term or medium-term? These are all things that are very important to discuss. Once, should I try physical or psychological therapy? Is it safe to exercise? What else can I do to relieve my pain? So you're inviting the clinician to actually reason with you and map out a plan that is bespoke and not a plan that is one size fits all. And if at all things worsen, what do I do? Who do I call? And of course, they will always tell you, if you develop the red flag symptoms, which are like numbness on the sit bone and the area where the back passage is, you can't move. And of course, the urine is pouring out of you involuntarily, or you can't wee at all. Then of course, they'll tell you, get an ambulance and come to A&E. But thank you very much for listening to me, and over to yourselves.
Thank you so much, Dr. Kamara. What a wonderful, comprehensive talk about chronic back pain. For those of you who aren't aware, this is university level. So this is the kind of thing that we got in medical school. So you know as much as a junior doctor. So thank you so much, Dr. Kamara. It was really, really comprehensive. And I really appreciate the fact that you gave us some hope at the end about things that one can do to cope with and manage chronic pain. Now, for time's sake, what we're going to do is I'm going to introduce our next speaker, because the questions are going to be grouped at the end of the session. So if we can spotlight Dr. Oge, I want to introduce Dr. Oge Ilozu, who is a GP working in London and a senior clinical advisor to the NHS London vaccination program. And she is going to talk to us about vaccines. So Dr. Oge, are you there?
I am here. Hello, everyone. I'm just going to share one slide. I'm not going to take up much of your time because you've already had a brilliant presentation. Can you see that okay? Can you see that slide okay? Yeah, lovely. So this is me, just basically introducing who I am. I'm a GP partner in training based in London, North London, but I've also been working as a senior clinical advisor with the vaccination program. Started 2.5 years ago when it was all about COVID, but obviously we've gone beyond COVID to other vaccinations. And I've also been working with the Legacy and Health Equity Partnership, which wants to close that equity gap in vaccine screening and access to good healthcare for Londoners, which I know is very much in line with the brilliant work that Khan's been doing. So I'm just here to say a little bit about the NHS winter vaccine campaign. So we are vaccinated against COVID. I've been out vaccinating my care homes and housebound patients this week, and we're also vaccinating against flu. So it's about being winter ready, being winter well. And a lot of people are like thinking COVID, there's the 3 C's that reduce access or reduce uptake of vaccination. And it's complacency. You also want a convenient place where you can get the vaccine, and complacency. So people think it's not a big issue. Why should we bother? So flu's been around for many years. Every winter, every autumn, we start usually around September, October, jabbing our at-risk population. So usually it's everyone over 65 and anyone with a medical condition. So our asthmatics, our diabetics, if you have a chronic illness, you'll be invited to get that flu vaccine. We're also vaccinating our 2- and 3-year-old toddlers and our school-age children. And if you're pregnant too. So those are the groups we're vaccinating against flu, been doing that for many years. COVID is also in that category now. It's a narrower group of people we're vaccinated against COVID. So basically wants to say quickly that if anyone's in a care home, or if you work in a care home, if you're a healthcare worker, if you're over 65 years old, and if you're in an at-risk category. Now, the at-risk category is a little bit narrower than the flu at-risk category, but anyone that's basically going through immunotherapy, anyone that has a condition that suppresses their immune system, anyone that has a severe, kidney disease, liver disease, very severe, that you're under a specialist and probably on a whole cocktail of medication. If you have moderate or severe learning disabilities, and if you have a severe mental health illness as well. These are some of the conditions that put you more at risk. So we want to vaccinate you as well as our pregnant population. So it's just to say that we are here going around inviting people for their COVID and their flu vaccines this winter. And we'll encourage you, if you're invited, to go out and get the vaccine. Really easy to book a vaccine now. They've made it very simple. You just literally type into your search engine, book a COVID-19 vaccine. It will ask you a few questions to check if you're eligible, ask you to put in your postcode, and it will give you a whole list of places near you, either near your work or near your home, that you can go and get vaccinated. So they've tried to make it as convenient as possible for everyone to get their jab. So that's basically all I wanted to say, just to remind everyone that COVID hasn't gone away. We don't see it as so much of a problem because we don't hear those numbers and those statistics that we heard during the pandemic about how many people dying, and we don't want to get there again. We've been vaccinating. This is the 3rd winter we're vaccinating. So we started in December 2020, and we've been doing it every spring for some very at-risk populations and much older, like over 75s, and every autumn since 2020. So we want to, vaccination is prevention. My mother always told me prevention is better than cure. We want to prevent people getting on well from COVID. We want to prevent the complications. We want to prevent the horrible ramifications of the pandemic in terms of lockdown societies and people being so scared. So vaccination is one of our strongest tools in our armory, in our health armory, to prevent severe illness and disease. We don't want to see people at risk being admitted to hospital. We don't want to see what we saw during the pandemic. So that's basically what I wanted to say. It's wonderful to be here. I think this health hour is a wonderful initiative. I've listened in myself a couple of times, learned lots, even as a GP. There's always room to learn. So thank you for having me, and hope to be back again another time soon. I'm here for any questions anyone may have. Thank you.
Wonderful. Thank you very much, Dr. Oge. Again, I remind everybody we need to start taking responsibility for our health and start taking it seriously. Okay, so we're going to go straight to the questions because our time is far spent, but haven't you got value from Dr. Kamara and Dr. Eluzo? Okay, so Dr. Kamara, I've got a question for you. Do you think young people, let's go now, do you think young people take longer to get a diagnosis of chronic pain? In your experience?
Yes, there's a short answer. If you want me to go into that, I'll go into it. But
yeah, I mean, I suppose why would be the next obvious question. But yeah,
good. Right. Well, why is that? Because I mean, as I said in my talk, as far as I know, the way I've been brought up, if you have a young child, you know, who has got pain, that is normally something of a red flag, as it were, and so that needs investigating as soon as possible. Something like discitis is really, really fatal in a young child. However, when you get onto the adolescents and then you get to the young adults, most of, I am ashamedly saying, most of our counterparts maybe underplayed, maybe trivialize it, and therein lies the danger whereby it becomes chronic because they just give them simple analgesia, maybe ask them to continue observing and things. And then, of course, the next thing you realize, it becomes a bigger problem. That's because clinically, you don't associate serious problems with a certain age group. This is just a given thing. And as I say, people have this issue of one size fits all approach, when in actual fact, you need to be thinking about bespoke, individualized, kind of management. So I'd say in general, chiefly or mainly, that's what happens because of the fact that we all sometimes guilty of that. You don't expect this to happen. But then nature has a way of springing surprises. So that's where that danger lies. Not because they don't know what to do with them. It's just the fact that you don't associate that kind of, danger. For example, a myeloma, you don't expect to have that kind of thing in a young person, but then sometimes it does happen. So they find that they have difficulties in accessing the kind of, if you like, management that they require because of their pain being so severe and being so intolerant, if you like, and yet they're not getting that from the GPs or from the healthcare provider because of the fact that there is this, as I say, one size fits all approach when it should be individualized. But that is my take on that. But generally, they find it difficult to access the facilities or the care that is available to them.
Thank you, Dr. Kamara. Question for you, Dr. Oge. One of the things that was an issue during the initial pandemic was concerns about vaccine safety. So how are you? Can you reassure people who are listening now? Because now we're 3 years in. Is there anything that you can say from a reassurance point of view?
Absolutely. So we've vaccinated literally millions of people now. And I know there's people that are really vocal about, the vaccine caused injury. There's a vaccine injury group. There are people that are convinced it's the vaccine. But ultimately, the numbers, the millions of people we vaccinated in the UK, and then the even more across the world, we now have data to show that this vaccine is safe, is effective, in that it prevents It prevents COVID infection itself, but even if you get COVID, you get a milder form. We don't want people ended up in hospital in ITU, like those awful scenes we saw during the pandemic. So we know flu's around, we know the common cold's around, there's lots of infections also circulating, but we have vaccination for a reason, to prevent complication and severe illness. So we know the vaccine is safe because we've vaccinated so many people now. Obviously, there's side effects to everything. So if someone truly believes there's a problem, then ask for help, go and talk to your GP, get referred to a specialist, let's do the due diligence. But the proportion of people who are going to be severely affected with a side effect is so minute compared to the overwhelming benefit of being vaccinated and protected and protecting our population at whole, because we don't live in silos. And vaccination, behind running water and sanitation, is the single most intervention that has saved countless lives over the decades. We've been vaccinating against all the different infectious diseases as well. We're just talking about the fact that we are seeing measles emerge in London because people aren't taking up the childhood MMR. And I'm as a GP, I've been a GP for 11 to 12 years now, coming to 12 years. I've not seen the case of measles in my clinical practice. I've had to go back and read what it looks like in case I now see it, because vaccination has meant I haven't seen it in my practice so far, yet I'm having to relearn in case I see it. Well, whereas we know if we catch up people on vaccination, we'll see it go down. We'll see those cases go down again. So vaccination works. There's no doubt about that. The evidence is very clear. And the safety profile of the COVID vaccines have been now proven because we've vaccinated so many people since we started 3 years ago now in December 2020.
Wonderful, wonderful. Thank you very, very much for that. And this is probably a question for both of you. So Dr. Kamara, with your hat as an ED specialist, and Dr. Oge as a GP. So people who have chronic pain and wanting to access pain management clinics, what would you say is the best route, and your idea about the time scale from referral to see? What would you say about that?
Well, I mean, it's a very ambiguous question, because pain management is not the first thing I'd say the first port of call, put it that way. It's not something I'll do immediately. Mm-hmm. I mean, as I say, pain in itself, within 12 weeks can remedy itself. Simple as that. 80 to 85% of that pain could actually get better. And in fact, it's funny how in the hospitals, we refer patients for physiotherapy, for example. And by the time, because of the waiting list being so long, by the time they get to be called upon to attend the clinics, they actually feel better. Now, you might say, miraculously or not, but that's what the body does. The body has got endorphins, internal, naturally endowed or given painkillers. They cope well with that. This is why I'm saying in the young, probably these are the kind of things you need to summon. You need to actually look into them, because the less you reach out for those painkillers that are opioids and things and have disastrous side effects, the better it is. I'm not saying suffer in silence, but what I'm saying is, pain management clinic is not the first thing I'd run to. This is probably the last, I'd say the bottom end of it, because there are other things you can do. Physio, exercise, painkillers, even the topical treatment things. These are all known to work. But to just say pain management team, I think it's not the right thing. And secondly, it's like, giving people the wrong impression, which is not necessarily what is to be done, because it could end up not working. And if it doesn't work for you, it's not successful, then obviously you're back to square one. So I'd say try all the things first. And probably if that doesn't work, then go back and then reassess, review. And in that way, you can then be taking it in a phased stage, as you were. Stage play, one thing hasn't worked, go for the other one. That doesn't work. But don't just go for the pain team because that doesn't work. And it's a long, long waiting list for it.
Yeah. So I'd reiterate that in terms of the waiting list in my area, 18 months if you're lucky, it's a long time. So and ultimately it's supposed to be a multidisciplinary approach, which has been addressed. You're supposed to see physio, you're supposed to address your mental health, you're supposed to look at physical health and other things that may be contributing to it. It's one of the hardest things we do as a GP, trying to manage pain and the cocktail of medication and wean people off, because ultimately it isn't the answer. But pain management teams, the waiting lists on the NHS at the moment are quite long. So this is such a timely topic in letting people know what they can do before it gets to that chronic phase and trying to prevent things from getting worse.
Fantastic. And I think one of the phrases you used, Dr. Kamara, was learned helplessness. You know, sometimes in a situation when something bad is happening, if we're not careful, there can be an inertia to action. Like, I'm just going to stay here, and I don't know whether it's a societal thing or a cultural thing. I'm going to wait for the solution to come to me rather than be proactive and say, this is my life, this is my body, I want to take it seriously. What can I do? And I think that's something that we would encourage everybody, because, you know, doctors, we're not magic. You know, as hard as we try, there are things that we are limited in our ability to help. And I think it's important for all of us in every aspect of our health to take as much responsibility for our health as possible. Now, Dr. Kamara and Dr. Oge, if you want to jump in, we talked about medical marijuana. A question here has been on the mental well-being side of things. Would medical marijuana help with managing illness?
Well, I put it this way: it's got its benefits, but it has to be for the right purposes. I stress that it's not something I'll jump to straight away. It's something that maybe, as I said, put it this way: there's certain things that work, and why would you leave them to go for marijuana? You see what I mean? You know, I don't think that's the right, but it's there for people to know it's there. And I think this is something that needs discussing and I say exploring in a way whereby it's a bespoke management plan, treatment plan. It's not like one size fits all. I keep repeating, because it's important to remember that what works for one person doesn't necessarily have to work for the other person. So saying marijuana medically approved is the key or the way forward. I disagree with that, and I wouldn't encourage that. You know, I wouldn't even recommend that to anybody. It's there as an option, but only for the person who would benefit from it. And it takes a lot more, like my colleague Dr. Oge is saying. When someone comes in with pain, remember, this is just like a set, and this set has to be divided or maybe sort of sequestrated, you know, in a way whereby you make sure this is not something else that may be causing it. For example, just for you to say this is psychogenic, for example, you have to have ruled out all the big things, all the big problems, the sinister problems, and then you can come down to the part that yes, indeed, this says no. As I said, blood tests, you know, X-rays, imaging and things, and then of course mental health and all of that would have been exhausted for it to say, well, okay, this is what we've done, it hasn't worked, this is what we've done, not worked, and therefore this is what is possible to work. We try it. If it works, then stay with it. If it doesn't work, then find something else. But marijuana, medically or not medically, is not the first thing I would want to.
Thank you.
Yeah, and just to say, as a GP, it's not something I can refer to. You know, it's not something that I have in my gift. So someone can't come to me and ask for a prescription and I can write something. It's not available in that way. So that's for my GP hats. From a personal side, I had a good friend who had sickle cell, and she lived in California, and it's obviously regulated and been made legal in certain ways there. And she found for her, it helped take the edge off, but she was still needing lots and lots of other treatments. So it's definitely not a panacea that will take everything away. And you have to be very careful about the side effects and the potential progression to other, you know, worrying side effects. And we know that it can be a gateway drug, some say, and also can cause psychosis and other really problematic side effects. So it definitely isn't a panacea, and it needs more regulation. But as a GP, it's not something I can prescribe at the moment in the UK. Just to make that clear, yeah.
Thank you, so nobody called Dr. Oge, please. Please, no prescriptions. Now, Dr. Oge, I know that you have to leave.
Yeah.
So is there anything you wanted to say before you go?
No, just thank you for having me, and happy to come back and do a fuller session. And thank you for all the brilliant work Khan's doing with these health hours.
Thank you so much for your time, Dr. Oge. You take care.
Bye-bye.
We'll see you later.
Thank you.
Dr. Kamara, let's keep on with the question. So we've got somebody asking, is there a link with rheumatoid arthritis and sickle cell trait, given that in both situations chronic pain is increased?
I mean, the only link I'd say is rheumatoid obviously runs in families. There's a genetic aspect to it. Sickle cell trait, as we know, is a genetic aspect to it. So maybe the two could be. And obviously, someone who's got rheumatoid and maybe a sickle cell trait will probably be more at risk, at a higher risk of developing chronic pain, as it were. But other than that, I mean, chronic pain can affect everybody, anybody. But,
absolutely. And one of the things I wanted to talk about, because we've talked a lot about side effects, I know that as a doctor, if the first thing the patient asks me is, oh, what are the side effects? then, because we have to accept as human beings that and there's data to suggest that my disposition to the intervention can often affect its success. There's data to suggest people with a positive attitude who have the same surgery recover quicker than people who enter the surgery with a negative attitude. Anything you want to say about that?
100%. I subscribe to that 100%. That's it. In fact, there's the studies, the articles out there, which actually, because I do medical legal reporting as well as, and that I find out that, people from, I don't want to be, if you like, pointing fingers, but people from the Eastern European aspect of our continent do fare better than the likes of our people here, our societies here, because probably they're more exposed to that kind of strenuous, cultural life, and so they cope better, and that helps them in terms of, and you find they come here, they get deconditioned, and indeed that cultural thing and that kind of aspect of thing creeps in. So it's important to remember that, as I say, nothing is the same with two people. It's different, and so therefore it needs to be individualized. It needs to be bespoke for that person and that person only.
Absolutely. Well, I mean, this has been a fantastic time. I'm aware of everybody's time. Is there any lasting thing, any last bit of wisdom you wanted to leave us with, Dr. Kamara, before we let you go?
Well, I say thank you for having me. I must be doing something that people are enjoying and wanting me to come back and things. So yeah, thank you for that. But I must stress the importance of trying to, so to speak, nip the thing in the bud before it gets to 12 weeks. It's important. And if by some misfortune it gets to beyond 12 weeks, please do not lose hope. Don't suffer in silence. There are facilities there to help combat this problem. As you can see, it's a rising problem. Even in our youths, it's there rising, especially after the COVID. So therefore, need I say more? We need to be in this thing together, and together we will succeed if we want to. Thank you.
Fantastic. Thank you very much, Dr. Kamara. This has been an amazing talk. I have learned and been reminded of so many things, and I'm sure everybody who is listening has got lots of value. So I'm going to hand over to our helper from the technical side of things who, I believe Fabiola is going to give us the closing slides and closing statements. Thank you so much for your time, everybody.
Thank you everyone, and we thank our guest speakers, Dr. Mohammed Kamara and Dr. Oge Ilozue, and also our host, Dr. Ayo Olatoye. Thank you for everyone who's here today, and I'll be closing today, and bear with me. Yeah. So we're going to talk about our next Catholic Health Hour session will take place next Saturday. Remember, it's the same time at 11 a.m. to 12:15, and turn in to benefit from information from our doctors who have more experience in health issues. So you can register anytime at info@can.org or visit our portal at Can. Taking care of your health starts with your diet and the physical activities. So you are invited to join our next Healthy Heart sessions. It's every Tuesday evening at 6:30 to 8 p.m. And we have our next session on Tuesday, 24th October. And the topic is the dietary supplements. And the host is Dr. Hiba, and the guest speaker will be Dr. Sylvia of Vobe. They are both registered nutritionists. We always have our physical instructor as well, Orlando Grant, on that evening. So feel free to register the event by visiting our portal. And also, are you at risk of type 2 diabetes? Individuals of Black ethnicity are more at risk of type 2 diabetes. I think everyone is aware of that, and we've heard that from different previous sessions we've had with our health hour. You have to understand the risk factor of getting tested. So please, and you have to get tested, please. So you can scan the QR code we have here, or you can visit our the NHS UK as well and understand the condition and diabetes. Yeah, this is the last chance. We have only 5 days to go to our Cannes Gala. This is the last chance for everyone to book for the Black History Month Gala Award and the 6th anniversary. Please buy your ticket. Feel free to join us on Saturday. We still have places available. Everyone is invited to join us. It's an evening where we celebrate Black history, culture, and notable achievement with our community. It's a space as well to connect and enjoy the night, entertainment, and all the ambience and the elegance of the unit. So please pay your ticket, scan the QR code. We would like to meet you on that Saturday, and you are invited. Come with all the family members. Everyone is invited. Even young people as well are invited on the evening. So welcome. We're looking forward to seeing you on that Saturday, 28th of October, which is next Saturday. Are you the giving type? There are so many ways that you can help others. One way is by donating your blood. We invite our community to sign up to become blood donors. So donating blood is a very important thing, and a Black individual can directly contribute to providing life-saving transfusion for those battling with sickle cell conditions. So you can become a member or a donor by scanning this QR code. So we have our Cannes Liga drop-in sessions, and our next session is on 26th of October at 6 p.m. to 7 p.m. The topic is just a general open floor. So the Cannes Legal drop-in session was created with the purpose to address the legal issues that are faced by the families and individuals of the Caribbean and African community. So please use the QR code to register and join the drop-in sessions. Also, we are calling in health professionals and nurses to join Cannes as volunteers and make an impact in our community events. In return, Cannes will offer the CPD point and the support from other health workers. So please, if you are interested, you can scan the QR code or contact June Green on the number provided or the email address, which is june@cannes.org.uk. Also, CAN is a lead partner at the London Inspire program, specifically developed to raise awareness and promote targeted interventions aimed at reducing health disparities faced by Black people in London. We are seeking London-based clinicians and healthcare professionals to join us. Please contact us on hello@inspireblackhealth.london or visit more of the website here that we are providing. So please join us. And also, we can't finish without thanking our partners. And we thank Anfield Caribbean Association, Rafa International Development Agency, the Royal Assembly Redeemed Christian Church of God, Croydon BME Forum, and last and not least, the Black Health Initiative. Thank you for joining us today. We hope to see you all next week, which is Saturday 28th, and we'll be happy as well to host you for our gala night on 28th. Thank you very much.
African Health Network, CAN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics that include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@can.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.